You are live now.
Well, welcome everyone. We're just letting everyone into the room. It just takes a few moments. Okay, welcome everyone to the next in the CovidSurg Medtronic series of lectures today. So this is our next webinar that today we're going to release new data that we have not released before on what happened with laparoscopic GI surgery at the start of the pandemic during wave 1. But we're also going to try and frame that data around restarting surgery and the rest of the surgical pathway, so that it is firstly relevant to everyone, and secondly, because what we are learning is you can't look at one part of the patient pathway and not look at the rest of the pathway when we're all trying to restart and serve elective surgery patients to the best of our abilities. So to summarize, we'll be looking at the laparoscopic gastrointestinal surgery data from the first wave, but we're going to be looking at it in the wider context of the surgical pathway too. As always, I'm very grateful to all of our sponsors who have supported this work, who are a wide group, and we will show later. But specifically, just there's been some help and assistance from Medtronic in launching this webinar, which we're grateful to them for. Now, to start, we're going to do some introductions. So I don't like to embarrass people too much, so I'll let people introduce themselves. But we like to keep these things very conversational, but you know, we've got our executive speakers today. So if we could start with, let's start with Neil. Hello, Neil.
Thank you, Neil. Hi, I'm Neil Smart, consultant colorectal surgeon in Exeter and also editor-in-chief of Colorectal Disease.
Then we'll go to Marlin.
Hi, Anil. Hi, everybody. My name is Malin Sund. I'm an editor for BGS and also professor of surgery in Umeå, northern Sweden, and in Helsinki in Finland.
To the other end of Europe, we'll go to Joanna.
Hello, everyone. I'm a general surgery trainee from Portugal, currently a research fellow in Birmingham, United Kingdom. Very nice to be here today.
And then to another part of the world, it's nice to see Ehab today.
Hello, everyone. I'm Ehab Alamir. I'm an assistant professor of surgery at Jazan University in Saudi Arabia, and I also lead CovidSurg project in Saudi Arabia. And it's my real pleasure to be here today.
And my name's Anil Bangu. I'm a consultant colorectal surgeon at the University of Birmingham, and I'm the chief orchestrator of the CovidSurg collaborative. Okay, let's immediately, if we could launch poll number 1, please. So we've got a few very quick questions that will pop onto the screen today. So poll number 1 will launch. In the meantime, Ehab, if you could just prepare to share your screen. Ehab's going to start, and he's going to start on the overall view of what the SARS-CoV-2 rate was during minimally invasive surgery in the first wave. So Ehab, if you're ready, I will pass over to you. Just getting there.
Do you see my screen, Anil?
I can. If you can make your slides full size, that'll be great. Yeah, that's great. Off you go.
Okay, so CovidSurg Collaborative has run a study on elective cancer surgery. This international multi-center cohort study has included adult patients who received elective surgery across several surgical oncology disciplines. But for the sake of today's discussion, we're going to focus on 3 gastrointestinal surgical oncology disciplines, which are colorectal cancer, gastroesophageal cancer, and hepatopancreatobiliary cancers. These patients were not suspected of having COVID-19 infection preoperatively, and all participating hospitals included patients starting from the local emergence of COVID-19 at their communities level until 19th of April of last year, 2020. So this was basically during the early phase of the pandemic. The main outcome measures that we looked at were post-operative COVID-19 infection up to 30 days after surgery. We also looked at post-operative pulmonary complications defined as either having pneumonia, ARDS, or unexpected ventilation, again, within 30 days of surgery. And in this data set, we compare 3 different groups. So group number 1 were patients who were suitable for minimally invasive surgery who did receive minimally invasive surgery. Group number 2 were patients not having minimally invasive surgery, so they received a planned open surgical approach. And the third group were patients who were suitable for minimally invasive surgery, but because of the pandemic, the plan was changed and they received open surgical approach. The overall participation in this study was really great. More than 3,300 patients were included from over 310 hospitals from 44 countries. So the first question we're going to discuss today is this: are minimally invasive patients at risk of post-operative COVID-19 infection? Was that the overall risk of these patients contracting COVID-19 infection after surgery was 4.3%. So basically, these patients were included in this study, and again, they didn't have any suspicion based on preoperative workup of having COVID-19 infection, and 4.3% of them developed the infection post-operatively. And what this chart is showing is that some groups might be more protected than others. For example, younger patients, female patients, patients with good performance status as evidenced by a low ECOG score. And also among the 3 GI surgical oncology groups we are comparing today, patients who undergo colorectal cancers also had lower risk of contracting COVID-19 infection. And finally, patients who come from a high incidence area, of course, had higher incidence of having this infection. And keep in mind, these numbers are from the early phase of the pandemic, but I think they still tell a story. If we are going to proceed with laparoscopic surgery with a second wave of COVID-19, we should be careful, and we should provide all the needed PPEs for our staff who works around these surgical patients when they come to our hospitals. And let me finish with just raising a few questions. And actually, I think these figures also might arise a few more questions. First of all, how does this increased risk of MIS patients contracting COVID-19 infection compare to patients who undergo open surgery? And the other question will be, what can we do to mitigate against this risk? And with that, I thank you.
Thank you very much, Ehab. That's great. And we'll stop you sharing your screen there. So we are going to come on to Joanna next, who's going to talk to us about the clinical effects in patients. But before we get there, if we could have the results of the first poll, please. In the meantime, let's just start with Neil. Neil, if we take this, let's just think about the theatre team and the surgical team. Do you think this information is important to the safety of the surgical teams? Do you think the surgical teams are going to be interested in this information? And if so, how do we use it?
Yes, certainly. I think they are. The issues that we've just seen highlighted are that, you can see the results on the screen, that only 59% of the people on the webinar have a situation where there is going to be these pathways in the hospital where there's a cold pathway, but the hospital's still got to deal with COVID patients. And I think knowing what we know about this data is going to be really useful, because we're still going to see COVID COVID patients cropping up around our hospitals, and even in areas where we thought they were cold or trying to be away from our elective surgical patients. I think what's really interesting about the data that we've just seen in particular, though, is the different levels of post-op COVID infection according to the different type of GI surgery. Looking at that data again, the colorectal one's 4%, nearly twice when you have the esophagogastric, when it was up at 7.5, 7.7%. That's really important for us. When you start going near the chest, the rate of patients getting problems with SARS afterwards is quite high in comparison to the colorectal, and that's going to be important for the teams who are looking after those patients, because those teams are going to be looking after them on the wards, looking after them on ITU, and then going to be back in the operating theatre. So how do we look after the teams looking after those patients? Things like regular testing, if they've got early symptoms, are we having to do lateral flow tests twice a week, other more formal PCR swabs? It's going to be really useful information for thinking about how we're going to implement safe pathways for patients and safe pathways for surgeons and the theatre teams.
Thank you. Marlon, around me, I've noticed some loosening of PPE in the operating theatre, as partly as the waves have come and gone, partly I think people have less concerns after a year of difficulty. How are things, firstly, what's the PPE situation in theatres around you, and secondly, does this data make you think that we need to continue as surgeons with a high level of PPE, or can we relax it?
Well, I think all of us experienced in the beginning of the first wave that there was a lack of PPE, and it was really hard to, at least in Sweden, we tried to save it up, and it was difficult. Now that's not a problem anymore. We also didn't really have any guidelines to go by, so there was a kind of a scare of this minimally invasive and laparoscopic surgery, at least in Sweden. So we just went by, open is better. And now I think the data shows that that's not the case in that sense. And I've also seen this kind of more relaxed attitude. And I don't think it's, we're in the midst of the second wave here now, and we don't have a cold pathway at our hospital, and most Swedish units don't have that. We have a socialized healthcare system, and all the acute hospitals take care of both COVID patients and also cancer patients. So they're going to get mixed. And I think that's going to be the really hard thing to change, even if we know that that's the way we should behave. It's not an easy way to change the whole system.
I'm going to move on to, if you could launch poll 2, and if Joanna, if you can just get ready to share your screen. So Joanna is going to talk about what the clinical effects of that first those rates that EHAB showed were on patients. Joanna, over to you.
Thank you, Anil. So I've been on this CovidSurg journey, and what I'm going to talk to you about now is more the patient's perspective. So obviously we need to collect data and reflect on data to know what we're going to do with staff and PPE. But we also want to know how did the way that we managed patients during the first wave actually impacted on patients themselves. So what we're going to do now is just to compare patient level outcomes for patients undergoing GI surgery during the first wave of the pandemic. And as EHAB said, this is a subset of patients from the early phase of the pandemic, 3,300 patients, and most of them, so 60% of them were suitable for minimally invasive surgery, and around 40% of them were not. So those patients were operated by an open surgery. They would always have been operated by an open surgery because they wouldn't be suitable for laparoscopy, but 60% of them were suitable for laparoscopy or minimally invasive surgery of some sort. And what we know is that during this early phase of the pandemic, 17% of those patients actually underwent an open procedure, and only 83% have actually gone for minimally invasive surgery. And this shift to open surgery was very much related to the concerns that you all have raised today about, is it safe to continue minimally invasive surgery? And obviously we wanted to know what was the consequence of that for our patients. So comparing these two groups of those who underwent planned minimally invasive surgery and those who were changed to an open approach because of COVID, what we see here is that the rate of pulmonary complications after surgery and of mortality after surgery is not significantly different between those two groups. And this is in our unadjusted and also adjusted analysis after adjusting for patient factors, disease factors, and for local community SARS-CoV-2 incidence. So we can tell that short-term pulmonary and mortality outcomes are not different between these two groups. What is different is how much they require from our hospital resources and our hospital systems, because what we do see here is that patients who were shifted to an open approach, they did have a higher ICU admission rate, and they did have a longer length of stay in hospital. So they will require more ITU capacity, they will require more ward capacity without a difference in outcomes for them in terms of pulmonary complications and mortality. So I would say that the main message to take from this data is actually that we have similar mortality and pulmonary complications after surgery if we keep doing minimally invasive surgery in patients who are suitable for that compared to patients who are shifted to open surgery. So it's safe to continue laparoscopic surgery, but we do know that if we change them to an open approach, we might need more ward and ITU capacity. And that is probably important when we are managing a healthcare system or a hospital or a surgical service, if that makes sense. And that was me for now.
Thank you, Joanna. If we could we have the results of poll 2, please? And a question's popped through on the chat from Joseph. So if anyone has questions or wants to make comments, please send them through. I would be interested if anyone could put something in the chat about whether they have a policy, a hospital policy for minimally invasive surgery during the pandemic, or if they have a policy for PPE in theatre, or if people do not have these things. So Joseph's asked on that line that he has seen loosening of PPE. Should we still be doing it even when there's a negative test? Well, I'll answer that and we'll hear from everyone else. But looking at this data, remember, these are patients who surgeons took to theatre either with a test that was negative or they were asymptomatic. So the assumption was that they had no infection. And still then, approximately about 5% of this cohort were coming through with a SARS-CoV-2 infection. I myself am not confident enough to ditch PPE. I use my personal form of PPE. And I don't know if anyone else has specific guidance in their hospitals, but I think I can see some people putting comments through. There's no minimally invasive surgery on positive patients. That's interesting. That's from Duke University. But let's go to EHAB. EHAB, in your environment, are you still continuing with laparoscopic surgery? Did it shut down? Have you restarted it?
Yes, actually, we did restart laparoscopic surgery. Although in Saudi Arabia, I think things are a little bit different from what you're having in Europe these days. I guess our first wave was actually like stretched over a longer period of time. So at the peak of the pandemic here, they very much shut down everything, including laparoscopic surgery. And still remember, based on the data published by CovidSurg Collaborative, at one point of time, they stopped all elective surgery altogether, waiting for more information to be available. But for now, what I'm saying is we hit like our low in the pandemic, and everything opened up again, and we started doing open surgeries, laparoscopic, and even elective, plastic, and bariatric. Everything opened up again, and now we're seeing again an increase in number of cases. And I think we might see more cases in the future, like in the near future, and we might have to shut down things again. But for now, we don't have much cases, for example, in my area, so we are doing laparoscopic surgery as usual.
Thank you. We in my environment, we switched away from minimally invasive surgery for the first wave, and then we've reintroduced it subsequently from that, and we can perform it. We're probably, Neil, I'll come to you after this, we're probably a little bit more restrictive in who we attempt laparoscopic surgery on now. So in my environment, we're probably a little bit more definitive. This will be a laparoscopic operation. This will be a sort of open operation. So, and part of that is the resource, because we don't get as much done on operating this. So Neil, what's it been like in your environment? And we've just had the poll result up as well. And generally only 11% of people are operating near their pre-COVID level. Over to you, Neil, for some interpretation, please.
Thank you very much. There've been some really interesting comments coming through, and I think it's worthwhile considering them in the context of answering your question. So I think when everything started in the first wave, we were in a position where we were data light. There wasn't much out there, and theoretical concerns about laparoscopic surgery had been raised. Now, the question is, was that justified? Now, some people, their instantaneous reaction goes, there is no data. But of course, evidence of absence is not absence of evidence is not evidence of absence. And some of the justification came from what happened during SARS-CoV-1 back in 2005. And there were lots of problems at that time with SARS transmission in hospitals, difficulty eradicating it. The only way to get rid of it from some of the theatre environments was to throw away all of the theatre kit in order to get rid of it from the hospital environment. And there were some issues about, well, what had we learned from that coronavirus pandemic? And the answer was not an awful lot when it came to accumulating data very quickly for this time round. When it came to looking at what we were going to do, we had issues in my own hospital, and I'm sure lots of other places did, where theatres were shut down very quickly because the spaces were turned into ITU beds to increase that capacity. And it meant that we were forced to operate with people who had no experience in the operating theatre of laparoscopic surgery. You know, we had theatre staff from ENT, from plastics, some orthopedics. So you couldn't reliably do the same sort of things you were doing before. So the conversion to open surgery was about what it was reasonable to do and do safely at that time in that environment. Now, of course, as the first wave fell away and we didn't need those ITU beds and we convert back to getting back to our own teams again, we've been able to go back to laparoscopic surgery. And of course, data is king. And we've seen the data from the CovidSurg collaborative really helped point us in the right direction that you can do laparoscopic surgery, and actually the issues surrounding laparoscopic surgery probably help get people out of hospital quicker, less ITU bed usage. That's a positive. But the coronavirus that these patients catch, if they're in a cold pathway and they still catch it afterwards, it's from other sources within the hospital. It's likely other patients. It's not what's going on in the operating theatre. It's the rest of the cold pathway that's really important. And perhaps the issue about what's happening in an operating theatre has been blown out of proportion.
I will come to you in a second, Marlon, just to ask you about your observation of restarting surgery and whether that low rate of operating applies in your environment. There's been a comment through from a couple of people, one from Sarah Duff, that society's issued guidance to restrict surgery. There was a lot of criticism around that. I agree, but I think everyone was trying their best. No one set out to harm anyone, and there was a lot of guidance. No one really knew what to do. But I'm just going to park that for a second, and Neil, I think I'll get you to answer that with learning lessons in a moment. But Marlon, over to you. So 11% of people only 11% of people are anywhere near their previous operating levels. So quick one from you, and then from Ehab. Does that reflect your environment?
I wouldn't say we're down to 11%, but we are not doing more than perhaps half. And of course, we already had some backlog going into the second wave, and now we're making it even higher. So I think since we now have the data on the importance of the cold environment, and I think we really need to go through that effort and try to, as far as we can, ensure that this is possible. It's not a question anymore about test capacity either, because that was a problem in the first wave. We couldn't test patients or personnel in the way that we can do now. So some things are actually better, and I think we need to really be harder on implementing that's the only way we can start actually starting up things while we have a second and a third wave.
Ehab, what proportion of elective activity are you back to?
Actually, I'd say very close to normal. I mean, we do have a large backlog of cases, waiting for operations. Unfortunately, I don't have any up-to-date numbers, but at our hospitals here, we're very close to where we were before the pandemic. But again, things are different. We don't have harsh winters like you guys do. But for the last week or two, cases are crawling up slowly, so this might change. But for now, I think we're good.
So I did agree that we would have some form of executive summaries from our colleagues, but just in lieu of those, perhaps some targeted thoughts. So Neil, do you want to make a few comments, especially around lessons learned? There've been a few questions and queries around that.
Yes, I think we're in a situation where I think compared to where things were when we had SARS-CoV-1 in 2005, we as a profession perhaps didn't get our act together as quickly as we ought to have done. And there were some slow responses. I think what we ought to make sure is that as we go forward with any future pandemics, that the lessons that we've learned this time are heeded. Early data collection, collaboration is clearly the key. CovidSurg has done a tremendous job, and it's led where perhaps other organisations should have come to the fore, and it's really done a great service for the surgical community around the globe. Answering some fundamental questions about the transmissibility of viruses is really important, and that's still actually not been answered definitively. Everyone has still had the index question that was raised about, can you transmit viruses by surgical smoke, or is it present in surgical smoke? Still hasn't definitively been looked at in a satisfactory way. There's a few small case series about limited evidence or absence in abdominal fluid at laparoscopy. One case report of SARS-CoV-2 virus particles doing PCR positive tests in the filters taken from the smoke extraction systems. but still not evidence of transmissibility to surgical or theatre staff. So still things that we haven't answered. It's just that by the fact that they don't seem to have happened, we assume that it isn't possible. But you know, some of the basic science questions we haven't really got there. Other lessons to learn, it's about how rapidly we respond to making sure that we have these clean, green pathways and the urgency and the strictness with which they should be implemented. They have worked well in some areas. There are some great examples in the NHS. There are some where it's not been so well done. And I think we need to make sure that we learn from the best practice of where it has happened well.
Thank you very much. Marlon, could we ask you for an overview, taking into account everything we've said of the Swedish situation, please?
So for some reason, people here maybe thought that we wouldn't get a pandemic or it wouldn't reach us. And then it came, and I would say that the society wasn't really prepared for it at all. And I just looked up the numbers today, and there, till summer, there were 90,000 operations that hadn't been taken. That was pretty good compared to the estimate from the modeling study that was published by the collaborative in BGS. So it was half. So I think we were a bit more pessimistic at some point than what turned out to be. But like I said, I think we have a slowness in changing the system and responding when something like this comes up. And I think one of the important things now is to learn from this to the next pandemic, because it won't be the last. So to take the best that we can learn from these studies and try to change our system to something that's more versatile and can have a more rapid response. And I must say that we have used these studies as a part of our national guidelines to actually try to implement safe surgery, because these are big studies and big cohorts. So it has had a great meaning for how we organized it in Sweden now.
Thank you. So in the second half, maybe we can pick up on how we can retain these lessons and what we need to do. But we will both please launch poll 3. But Joanna, we're going to move to a couple of cases now. So these are really short cases, but they are targeted around restarting surgery and what we can say to our teams and what we need to do and how we can use the evidence. So a quick case summary, and then we're going to do some discussion around it. So over to you, Joanna.
Sure, Neil. I think these cases will be quite interesting because they're probably going to get us discussing what we need to do also to recover from this. And a lot of comments on the chat I've seen mention how this will create a huge problem even when COVID is not peaking. And maybe these cases can also promote the discussion around what we can do to actually prioritize some patients and do the surgery that needs to be done around the world. So the first case we have here is a 77-year-old man with a right colon adenocarcinoma T3N1 with a performance status of ECOG1 and a cardiac index risk of 2. So a moderate risk 77-year-old man with a right colon adenocarcinoma who was consented to have a laparoscopic right colectomy done. And I think that probably the challenge you want to promote around the room is how would we make this surgery happen? Would it happen in a safe environment? What do we need to account for within that safe environment? And then we can perhaps share some bits of data to support that as well. Is that?
So let's go Neil, Ehab, Marlon. So Neil, in your environment, how would you get this done?
So yeah, this chap would be considered for a laparoscopic right hemicolectomy with us. He would see me in an outpatient clinic. I have to say we still do face-to-face, but we have our PPE on in the outpatient clinic. So everyone in the room will have their face mask, goggles, etc. And for me, he would go to our pre-assessment pathway, which might be done telephone or video, depending. It might be done face-to-face in this instance with his cardiac issues and his age, looking for other occult comorbidities, so get seen by one of the anaesthetists in the pre-assessment clinic. He would get his dedicated COVID swabs done 3 days before he would come into hospital. He would turn up on the day of surgery, and it would be expected that he would self-isolate in the intervening period between having his COVID swab 3 days before, and all of his household would too. Come in on the day of surgery, go for his laparoscopic right hemicolectomy, and he would go back to a ward where our essentially elective surgical patients go. All of the staff on the ward all have their PPE. They all get lateral flow tested twice a week. Mostly we would carry on with our standard enhanced recovery pathway and try and get them up and about, mobilizing as quickly as possible, eating and drinking all the tubes out as quickly as possible. Home, for a gentleman like this, we would estimate probably 4 to 5 days. So that's what we'd really push for. I mean, in some respects, there've been a couple of cases where we've, because of the pandemic and wanting to get people out of hospital quicker, some of the ideas that our French counterparts have had about 23-hour, 24-hour stay in selected patients started to come to the fore, made us think about it. Not to be implemented now, but certainly it's highlighted that French work about very rapid RS pathways for select patients. Certainly something we want to look at after we're out of the COVID times, because it's evident that you can do that. Probably not for this gentleman, but certainly for younger, fitter patients, definitely. So that's where we would go.
Thank you. Ehab, would you get this in terms of testings in your environment? Would this guy get preoperative testing? Would he be in a COVID-free ward?
Yes, exactly. So, I mean, nothing special will be actually done for this patient. He'll get the usual evaluation by medical team, cardiology, anesthesia, and then once they all decide he's fit for surgery, he will be admitted. Usually, they will admit patients like a day or two before surgery to reserve a bed, and also, you know, to finish any preparation that he needs before surgery. Again, right in my area, I don't think they don't even implement like routine pre-op testing anymore at this stage. If there is any suspicion, like there are some surveys that patients and families will fill before any admission that will ask them, you know, about any risk factors for contracting COVID-19, any contact with sick people. If this patient is low risk for contracting the disease at the community level, you don't necessarily get pre-op testing. Although, like more people, some people are still actually doing the test, even if the survey, you know, says otherwise. And then, you know, he'll go for his laparoscopic surgery. And we do implement ERAS system for speed recovery. So hopefully within a few days, this patient will be able to eat and, you know, have some bowel function, and then he'll go home.
Very interesting. So a couple of geographical differences there. The reliance on symptom questionnaires rather than testing, and the admission of patients before the operation to complete testing and other processes. Those are probably slightly different to Western European practices, which is really interesting. And Marlon, would this guy get, what would he get in your environment?
No, he would get a laparoscopic operation now too. Probably he wouldn't have had that in the spring, but now he would. He would be tested. I'm quite impressed what Neil said about testing the personnel in the wards. We don't do that. Maybe we should. But all the patients that undergo this type of surgery are tested. One thing I wanted to raise is that maybe this man already would have been vaccinated. actually. He's 77 years old and the recommendation is above 70, and cancer patients are high risk, so they are ahead in the vaccination queue. So that would be one thing that might be that he is at a lower risk because of that.
And that raises an interesting point around vaccines and who is being vaccinated and who is not. We're about to release some data on that. We probably can't get into it now, but in the UK, we would expect this man to have been vaccinated as part of the prioritization process. So Joanna, let's just go back to you just quite quickly. Let's look at the data that CovidSurg has provided to support these decisions, please.
Sure. So what the data shows, and I'm going to show you bits of data that were published in different papers. And this first slide is about patient prioritization that, as I said, is probably something that we will have to keep with us for quite a long time. So the CovidSurg collaborative come out with a report based on our data and how to prioritize patients during the pandemic. And obviously this patient would be high priority because obviously the surgery will have a survival impact on this patient, and it's cancer surgery. So it's obviously one of our top priorities, which would be good in some sense for this patient. About how to make this surgery as safe as possible for this patient. Obviously, testing needs some evidence behind it. And what we found within the CovidSurg data is that compared to no testing at all, swab testing is actually the best form of testing to prevent post-operative pulmonary complications when compared to CT scan and swab in CT. So this is statistically significant and adjusted analysis comparing swab tests with no test. And we do know that swab testing is good to prevent pulmonary complications after surgery. And about the location of surgery, we've gathered evidence around COVID-free pathways, and we know that patients undergoing surgery within a COVID-free pathway have a much lower rate of pulmonary complications after surgery compared to patients who cross their paths with COVID patients either in theatre or ward or ITU. If the environment is not segregated, they are at higher risk of pulmonary complications. So testing and location of surgery or location of the perioperative pathway are obviously very important to make surgery safe. And regarding the surgical approach, and just to touch on something that Neil Smart also mentioned, we don't have really a lot of evidence behind laparoscopy and open surgery, and to say that laparoscopy generates more SARS-CoV aerosolization within theatre. The systematic review that is done about that doesn't support any withdrawal of laparoscopic surgery. So actually, they recommend that laparoscopy should be performed whenever it's of patient benefit. And obviously, PPE and closed circuit filtration systems should be in place just to prevent any theoretical risk, of course, of a negative patient or a pseudo-negative patient to be transmitting SARS-CoV-2 within the theatre environment.
Thank you. Let's just look, could we launch the result of poll 3, please? So this was whether people are managing to perform minimally invasive surgery. So about 3/4 of people are. About 20% of people are in the middle, they're not quite fully recovered, and 10% of people are performing open surgery. That's interesting. So could we please, Ehab, we're going to go to a slightly different type of case now. If you could perhaps load your slide, if you could manage that, please, and just discuss the final case. So Ehab's going to discuss this. While you just get your slide, we're going to discuss a slightly different kind of case. You can just read it out if you prefer, Ehab, if the slides are a different problem.
Okay, let me share my screen. Here we go.
Okay, you can just talk over that, Ehab.
Yes. So this is a young male patient with symptomatic inguinal hernia for 6 months. In the last 2 months, he had 3 admissions to the emergency department for pain control. This patient is healthy otherwise. So this is symptomatic. He was consented for elective hernia repair.
Okay.
Like me to keep going?
Yeah, thank you. Let's pause there. So we've got a young man who's got an inguinal hernia. So slightly different case, slightly different approach, but he's coming in and out as an emergency. And so, you know, the question is now, what do we do with this patient? And I think the context is, in my environment, inguinal hernia is not classed as a priority case. It's, you know, the highest priority of cancer patients. So getting this type of case done on an elective list at the moment, it is not easily done. And so, Neil, is this an elective case? Does this guy just wait? Or should we be looking to prioritize him in a different way?
It's difficult, isn't it? There is that real challenge that you've alluded to here, and I know that you've written extensively about in the past. These patients often get a quality of service in some healthcare systems which is less than excellent because they're deemed to be low priority. But actually, if they strangulate, you know, they can end up costing significant amounts of money. And I'll say openly that, you know, we've got several patients on our wards at the moment who have come to harm during COVID times because their hernias have strangulated. They've ended up with dead gut in them. They've had complex operations, ended up with intestinal failure, TPN dependent, 6, 8, 9 months in hospital. So take them lightly at your own risk. This is one of those cases where par excellence, I think there's the real case for dedicated cold sites in community hospitals with ring-fenced green pathways where you can prioritize people like this for laparoscopic surgery, because he in particular would benefit from a laparoscopic approach to his inguinal hernia. He would get much less pain, much sooner return to work, depending upon what his job is, much better quality of life. So I think, you know, these patients have been a real second victim of the pandemic, and they deserve some attention, because its impact on his quality of life, his ability to work, and avoiding some of the most serious complications that hernias can give you. It's really important that we pay attention to them, particularly with 3 emergency department attendances in 2 months. It's a harbinger that something's going to happen.
Marlin, are you managing to get any day case or non-cancer surgery done?
Yes, we do, because Sweden has gone through a big process of centralizing cancer surgery. So there's a lot of acute care hospitals that do not do cancer surgery. And of course, they do hernia and cholecystectomies and more of these general surgery procedures. So this patient, we would have had him quite high up on an emergency operation, or at least within a couple of weeks, because of these 3 admissions. And he would have been operated at such a site. And if he would have come first to a university hospital, likely he would have been sent to a smaller hospital to do this operation. But we don't have cold, smaller hospitals either, because all acute hospitals take care of COVID patients.
Thank you. If we could launch the final poll, please. And I guess that it does make me think we're straying slightly, but what we're going to do about day case surgery as well, and that might need a slightly different discussion. This is really about laparoscopic GI surgery and ensuring cold pathways, but there's probably a discussion to have about day case surgery as well, but we'll save that for another time. Ehab, while your slides are up, could you just show us the evidence supporting the decisions for this man, please?
Yes, sure. So again, if we use the same model that was used by Joanna, As you all know, usually inguinal hernia repair is a low morbidity case that could be done as a day case surgery. But again, if we can do the surgery sooner, we might prevent an emergency presentation in the future where the risk will be even higher with this patient. So the data we're going to share here is this. So Joanna has discussed using a green pathway or COVID-19 free pathway. But the other thing we can do to decrease the infection risk in these patients is to implement preoperative testing pathways. And actually, we have shown in some previous CovidSurg collaborative publications that routine pre-op swab testing has a benefit across all settings, including for minor surgery, especially if the incidence of COVID-19 infection is high in that community. And what these numbers are showing is basically number of patients we need to swab pre-op to prevent one pulmonary complications.
Thanks very much. So we can begin to bring some structure to these cases, test them, cold pathway, prioritization. And there've been quite a lot of questions coming through about timing of surgery in SARS positive patients. And we are trying to release some data on that as soon as we can. If anyone has an urgent patient they would like advice on, if they contact us, we will send a preprint of that data to help support immediate decision making. But I think operating on patients with SARS is quite a complex business, and I don't think we'll do it justice by dealing with it in a minute or two now, I'm afraid. I think we probably need to talk about that separately because we're going to see more and more of those patients. And it's not, what we don't want to do is give casual advice. You need data-driven approaches to making those decisions. But if anyone has an impending patient in front of them who has a cancer and a positive nasal swab and you need some specific advice, if you contact us separately, I think we can help provide some of that advice. Could we have the result of that final poll, please, just before we wrap up? And so there it is. So in terms of getting general advice, I think, so about half of people need some form of advice to take this forward, which is really interesting. So just before we wrap up, I'd like to hear from everyone again, please, just if they could leave us with some final thoughts, perhaps not just about this, but what the next steps are in our evolution of restarting elective surgery. So we'll go in the order I can see people on my screen, which is different to the way you can see them. So Ehab, we'll stop you sharing your screen and we'll go over to, can we start with Marlin, please? Marlin, any overall views on what our next steps are?
Well, I think we need to be prepared now of the waves that are to come and the next pandemics, and take this as a learning thing also. And I think us and on the floor, clinicians, we tend to think we have this evidence, but I think what we need to do is to really try to push the hospital administration, and in Sweden this is a politically run system, so that we need to really get these changes, because the changes need to come from higher up than what we can actually do on the floor. So I think also to work against those that level of decision making is important.
Joanna, what do you think is next?
Thank you. So I think I agree with you, Marlon, and I come from a very similar health system. And whilst I agree that we need to take this to the next level of decision, I also think that surgeons can be action makers there, so they can get this data, they can show it to the right people, and they can be change makers within their own systems. So I think that's the way forward. And going forward, I think we probably need to think about how can we make our systems more resilient? So how can we make our surgical services capable of delivering surgery, even when the hospital is subjected to different pressures over time, because now it's COVID, and then it's going to be the flu, and then it's going to be something else. And how can we ensure that we have the strength to keep operating the patients who need to be operated and for whom surgery is actually very valuable. I think that's the way forward, probably.
Ehab, what do you think is next in our decision making around COVID and surgery?
No, I would agree with whatever was said. Now, I might add, if we can promote more cooperation between, different scientific societies and bodies to do more collaboration and to disseminate the findings, because I think decision makers are also looking for these, papers and for evidence-based in Serbia. And as you know, every time we publish some data, I actually try to communicate with people who are in charge, and they do listen. So I believe once we have strong evidence and we work on dissemination, people would listen and things would change on the floor.
And over to Neil. What do you think is next for us?
I think it's already been said, but I'll be slightly more explicit about it. And it's the future waves, particularly with the variant coronaviruses that have arisen in South Africa and in parts of the United Kingdom, and how vaccine effectiveness relates to them, and then what we're going to do when we get waves of those infections which come through and patients who've been vaccinated but still get infected. Do we need new types of vaccination? When do we do that? How are we going to have surgical pathways which are going to allow us to deal with those types of patients? It's going to be with us for a long time yet. I don't think this is going away in a hurry.
Thank you. So look, thank you to all the panelists, and thank you for everyone for joining today. I'll just leave with a final comment that if I take this all together, we need to be able to push messages to surgical teams clearly. And secondly, we need to be able to harness this knowledge for the future. I think we're going to see a lot of aspects of society moving to pandemic resistance, airlines, supermarkets, not just for now, but for everything. And I think in surgery, there needs to be a global strategy so that everyone can look at making their elective surgical systems pandemic resistant. So what I'm just wondering is whether we should challenge ourselves, and if the CovidSurg Collaborative needs to develop an online live toolkit where people can very easily access this data. Perhaps they can even self-certify their hospital pathways as being COVID-free or not. And so they can identify how they can improve. And with that toolkit, people can then have the necessary clear, direct lessons, certification, perhaps some CPD. And if they wrap that all up, that will help people directly implement the lessons from CovidSurg. That's the sort of challenge. It might be interesting in the next few days to hear back from anyone listening, or the panelists, about whether that would be worthwhile. I hope no one shakes their heads immediately. But look, thank you very much to everyone. Thank you to the attendees, and thank you very much for the panelists. We are looking to launch more webinars as we get data coming. And so we are, just to tip the balance, we're looking to do one around vaccinations. We're looking at data around VTE and SARS-CoV-2 in surgical patients. Do we need to extend thromboprophylaxis? And we're looking at timing of surgery in a SARS-CoV-2 patient. And so as soon as that data is slightly mature, we don't want to release it too early and release anything incorrect. As soon as it's mature, we will release that in webinars and journals urgently. But for today, thank you very much, everyone.
Thank you. Bye-bye.
So we're going to close the session.